Good afternoon, and in the coming 10 minutes, I would be speaking on diagnostic vitrectomy in uveitis. So, Dr. Somshila, we are moving from outside to in. We had Dr. Lakshmi, who told us about orbital biopsies. Then we had Dr. Somshila, who concentrated on the keratitis sampling. And now I would be speaking on vitrectomy in various indications for uveitis. So whenever we are doing a vitrectomy, even for a diagnostic purpose, it of course needs an informed consent, and you have to explain to the patient very clearly that it is being done for a diagnostic purpose and it's not going to be having any impact on the visual recovery or any, it's not being done for a therapeutic purpose. You have to, of course, follow strict aseptic precautions, adequate anesthesia is required, and of course, a teamwork is required because that sample, what you're collecting, is an important sample which is going to be ultimately helping you in the diagnosis and planning the management for the patient. So it's a very important sample, so you must have or take the sample in coordination with your lab facilities. As far as the vitreous sampling is concerned, it helps in cases of unknown etiology by identifying specific causative agents like an endophthalmitis and precise histopathological grouping of the involved entities. The recent advances in the form of MIVS, of course, has made this procedure very safe, and it should be considered sooner than later. So earlier on, when we used to have a 20-gauge vitrectomy, we used to keep postponing because we felt that it had a lot of complications. But in today's time, with MIVS cutters like a 25-gauge or a 27-gauge, we, intervene much earlier. As far as the indications of a diagnostic vitrectomy in uveitis is concerned, you can have both infectious and non-infectious etiologies. Infectious, of course, the most important being endophthalmitis because of various organisms. We can also have, indications like any viral retinitis where you are a little lost with the diagnosis. As far as non-infectious is concerned, we can have intraocular lymphoma. Again, that is a great mimicker, and we are often, not able to diagnose, and sometimes we have to plunge to doing a diagnostic vitrectomy. Any kind of non-infectious uveitis, and of course, very important again is the masquerades. So this is, or any patient who is showing an atypical response to the clinical diagnosis that you've made and the management that you are doing. And if the patient is not showing the response that you were expecting, then probably it's time to intervene and do a interventional diagnostic procedure. As far as the contraindications are concerned, well, if you can make the diagnosis with a non-invasive investigation, obviously you're going to prefer that to, doing any surgical intervention. Friable tumors, again, it may not be very useful and unlikely to alter the management. So whatever management, if you decide that I'm going to be treating this patient with steroids, the patient is showing a response, then it's no point, disturbing the management, because in any case, you're not going to be altering your management. Now, this is a short video. So here we have the cutter, we have the aspiration tubing, and we have the cutter tubing. So we basically disconnect from in between where you have the aspiration tubing, and we connect this to a 2 cc syringe. And this is going to be basically that we are going to be wanting to collect an undiluted sample. That's okay. So this is basically when we have not started the infusion cannula and we are just wanting to collect an undiluted vitreous sample. You're going to be connecting your vitrectomy cutter, and you're going to be asking your assistant to take the aspirate in the that we are wanting to collect more and more sample, and sometimes the patient's eye may start developing hypotony. So it's a good idea, rather than connecting it to the infusion fluid, you can connect it to an air infusion, and the moment you start having a hypotony, you can start your air infusion. This is going to help in avoiding the hypotony, and it is going to avoid the dilution of the sample. Now, once you've got the sample in the syringe, it's a good idea to cover it up with a needle and rotate this needle so that there's no contamination, and cover it up with a sterile cap. We take out all kind of air bubbles that are going to be there in the sample. So either you pack it in a sterile packing, And this is well labeled with patient details and sent to the laboratory for further investigations. The other option is that you are going to plate the sample in the operation theater itself. So you make a preparation, you take a separate table, you are going to put all the medias over it, and you're going to put a small amount of the vitreous sample that you have collected in the various medias. And then these are going to be then transported to your lab facilities. The precaution that has to be taken, of course, is that there is no element of contamination in your collection and transfer of these samples to the lab. So what we often do is that we inform the lab that we are now taking up this case for the sampling, and within half an hour you are going to have the samples ready and sent to your lab. So please be ready, because sometimes they've gone for lunch or they're not aware, then the sample keeps lying there and there's a potential risk of contamination, so you possibly don't want that. It's a good idea also to plate 2 glass slides. And this again is going to be extremely useful while collecting the samples. Now, as far as certain special tips for vitreous sampling is concerned, I already told you it's a good idea to connect it to an air infusion rather than a fluid infusion, because this avoids the dilution and avoids hypotony. Now, coming to intraocular lymphoma, we have certain special things which we have to keep in mind. One is that we have to stop the oral steroids about 2 weeks prior to sampling. So we all know that the intraocular lymphomas, they respond to steroids and your yield is going to be much less. So if the patient, you are suspecting an intraocular lymphoma, it's a good idea to stop the steroids at least 2 weeks prior to you collecting the sample. The lab is very much informed well in advance, because these cells are very much, they die very fast. So you have to inform your lab much in advance that you will be sending this sample. The cut rate again is kept very low, something like a 600 cuts per minute, and this is because the cells are again very fragile and you don't want those cells to get denatured with your cutter. All the vitreous sample with the fluid in the cassette again is collected. We had a nice presentation yesterday by Dr. Mohit Dogra, where he had actually used a soft tip cannula, something like a snake flute, where he had collected the sample from the subretinal space over the lesion where he was suspecting an intraocular lymphoma. So that is another technique, but that is going to be only valid for those lesions which are away from the macular area and not involving the macular area. And of course, I mentioned in other situations, it's going to be a good idea to do the plating in the operation theater. Now, just a small case example. This is an 18-year-old boy from Bihar, a gradual painless diminution of vision in the left eye for last 6 months with no significant systemic or contact history, very low socioeconomic status. The patient apparently presented with this large yellowish subretinal abscess looking kind of lesion in the macular area. You do see subretinal fluid involving the macular area, which has detached the macula. And on doing a fundus fluorescein angiography, we do find an element of a hot disc, and some kind of a mottled hyperfluorescence is what we had seen on fundus fluorescein angiography. On a B scan, there was just a circumscribed lesion which was of a significant size over the posterior pole, which had a high surface reflectivity and a homogeneous low to moderate internal reflectivity with minimal SRF. So the provisional diagnosis, seeing to the profile of the patient we made, was of a subretinal abscess, secondary to tuberculosis, which is very common in the area where I practice, and other chronic infections, of course, were fungal. And the last thing which we had kept in the differential diagnosis was a lymphoproliferative disorder, being a child. Now, this is the left eye fundus. You again find this, this is what I had shown, a large lesion, very much looking like an abscess. So we were quite lost on the diagnosis of this particular patient, so we went ahead and did a vitreous biopsy. And we just collected an undiluted sample going very close to the lesion. I did not have the heart to collect the sample from the subretinal space because he was a young child. So I just restricted myself to collecting an undiluted vitreous sample going as close as possible over the lesion. And the vitreous biopsy, of course, it showed growth on the culture plate, and that was these funny, creamy looking lesions. And we had, on the staining, we had a few gram-positive filamentous bacilli. So this was detected as a nocardia species, which probably would have never thought of if we had not done the vitreous biopsy and sent it for a culture. The acid-fast staining, of course, was negative, and the treatment was accordingly modified. The patient was sent for an MRI brain to rule out intracranial nocardiosis, and the patient was started on sulfamethoxazole and trimethoprim along with oral steroids, and you find that the patient responded very well to the treatment and improved vision with complete resolution of the subretinal fluid and the regression of the lesion. So this is another patient of a 14-year-old female patient presenting to our hospital with diminution of vision in the left eye for last 6 months. There was no relevant systemic history. The anterior segment examination, the right eye vision was 612. The left eye was finger counting at 3 meters. There were pigments all over the anterior lens capsule. And this is how the right eye fundus looked. You had a hyperemic disc, very hazy media with the details of the fundus barely visible. An intense vitritis was present, and this is how the left eye appeared. Again, a very hyperemic swollen disc. You had these yellowish lesions underneath the blood vessels with extensive vitritis. And so this is how both the eyes, the fundus, they appeared. Now, in this particular patient, we had a role where it was diagnostic as well as therapeutic both. So we did go ahead and do a vitrectomy in both the eyes. Apparently, the visual recovery in the right eye was very good. It came back to 6/9. And in the left eye, this young child continued to have a poor vision of 4/60. Now, the sample which was collected, the vitreous sample was sent for PCR, and it came out to be positive for Mycobacterium tuberculosis. And subsequently, this patient was detected with miliary tuberculosis, which was multi-drug resistant. So apparently, we were able to put this patient on the right track of management just because we had collected the sample. It was not only subjected to PCR, but also to gene expert PCR, which detected that the patient was having indeed a multi-drug resistant tuberculosis. So I just take this opportunity also to invite all of you to our forthcoming annual Uveitis Society of India conference, which is going to be a physical conference at Hyderabad on 14th, 15th, and 16th of October. So kindly register because the early bird registration is already open. And also to VRSI, which is going to be at Nagpur from 2nd to 4th of December. We do have a stall in the trade area where you can do an early bird registration. So thank you so much. If there are any questions, I'll be happy to take them.
I would like to ask, sometimes we take vitreous aspirates while giving the intravitreal injections. So in what conditions we must go for vitrectomy other than vitreous aspirate?
You are asking?
Yeah, vitreous biopsy by vitrectomy.
So if I get your question right, what you are saying is that when do we go ahead for a vitrectomy and when do we take a vitreous sample?
Yeah,
right?
definitely.
So in today's time where we are having MIBS, once we go inside, like we are not really taking an aspirate of the vitreous because that is causing an unnecessary traction. What we are doing is we are using either a 25 gauge or a 27 gauge cutter. And once we go inside, if we are like in a case of endophthalmitis, we would collect the sample and do a core vitrectomy along with it. Pure vitreous sample collection is going to be done in very limited cases, like I showed you in a patient of an intraocular lymphoma, where we are just wanting to collect the sample for a diagnostic purpose, but there also we are not taking an aspirate with a needle. We will go ahead inside the cutter, so whatever we can clear up, we will try to do that. I hope that answers your question.
Thank you.
Cardiac patient, did you do the vitreous biopsy first go or after treating for?
No, sir, I actually, that slide apparently was missing. So the patient was put on a broad spectrum antibiotic like an ofloxacin and steroids. And the patient was from Bihar, not ready to stay back in Delhi. So he was sent back on ofloxacin and steroid. Much later, once, he came back, I found that there was no response after a significant treatment with the broad spectrum antibiotic and steroid. That's the time when we plunged into it.
The question is that would it be better in some of these cases to do biopsy first also? Patient is willing.
It's only, sir, that the patient was not willing because it was a young child, so the father was not consenting for a surgical intervention.
Patient is willing and
Yes, absolutely. We often do that. Ma'am, your comments?